Hey everybody, and welcome back to the Overrun podcast. My name is Ed Bowder. Dan Schwester is coming to join me later on. We just got back from the National Conference on EMS in Atlantic City, and we've got a lot of really good talk coming at you. So before we take too much more of your time, let's go ahead and head over to Dr. Devin Dromgoole, who's going to talk about ultrasound, and then we'll get into some more talks from the conference. We'll talk to you on the other side.
Hey, Devin, good to see you.
Hey, good to see you, sir.
Guys, Ed Bowder here at the New Jersey Conference on EMS. I'm here with Dr. Devin Dromgoole, who's joining us. Again, he's been talking about ultrasound for the past couple of years, and he was on an episode last year. So we're catching up with him here at the conference. Devin, what'd you talk about this year?
Yeah, so I was talking about ultrasound for EMS and really where the state of the science is in terms of having it applicable to pre-hospital use and also just the feasibility of even doing it pre-hospital.
Right. And I think that's one of the big concerns that a lot of people talk about is the cost of getting any of the probes out on the trucks, right? Whether it's the brand, it doesn't really matter. I think when people see the sticker, they get kind of scared. So is that something that's changing? Is that making it a little bit more easy to get on the trucks? Because I think the worry is like, once we get it out, we can use it clinically. It's just a matter of getting it to the trucks first. So how are we in reducing that?
Yeah, I mean, I think in EMS, we've spent more on less in general.
Right.
That's how I feel. And the prices are coming down. They're still up there, but they're not what they used to be.
Okay.
And I think that it's economical when you look at how much you may save in like going to different other centers, like going to a trauma center when they didn't need to go, helicopter utilization for certain patients and maybe don't need to go because you can have a negative fast exam.
Mm-hmm.
Cases like that, I think it may actually end up being like, they come out in the wash, really.
So I think that ultrasound is kind of turning into the new 12 lead a little bit. We talked about this on the show. So as far as the use of it is concerned, because I always worry when there's I hate to say new toy, but when there's a new thing that comes out, everyone talks about like, oh, it's the new thing, it's the new fad. So talk to us about the actual use and applicability of ultrasound out in the field, because it's important. Like we'll just accept it as an important thing. Well, let's talk about how we can actually use it.
Yeah, so there's some people that claim it's the new stethoscope, and that we're all going to walk around with butterflies, or I'm not endorsing any brand, but we're going to walk around with portable ultrasounds in our pockets, right, and get rid of the stethoscope. I don't think we're at that point yet, and I don't think we should ever lose that art of the physical exam. But then again, EMS works in settings where there is not necessarily always the best situation to do a good physical exam. Right. You think about you're in the back of an ambulance, lights and sirens are blaring, you're on the way up to the trauma center, you're trying to decide, does this person have a pneumothorax or not? Sometimes it's difficult to listen to lung sounds, but what doesn't change in that environment is an image, is an ultrasound.
Yeah. So using it in the back of the truck, the next thing is that we have to teach people how to use the tools properly. Is there a thought, or is there a class that people can take just for ultrasound? Or, because I know it's a subspecialty in medicine. So when we have that gap of education, how difficult do you think it is to actually teach EMS providers how to appropriately use ultrasound?
So in my lecture this morning at the conference, I actually presented a number of research studies that were some were practical, some were more simulation and like classroom based. But there is evidence that paramedics and EMT basics actually in some studies can do these studies, get quality images and interpret them correctly in a reliable fashion. So I think that we're there.
And about how long would a class like that take? Are we talking is this a 10-minute in-service you can do like when you see a staff on the road? Or is this more like an annual competencies thing? Or is this something where get your whole crew together, get everyone in a room, full day, learn everything?
I think that, so the research that's out there now seems to be more of a like didactic scheduled 4-hour, 8-hour, 16-hour class.
Right.
I think with everything, there's always some room for interpretation. I could see a world where just how paramedic students go to the ER for IV time, right? You could have them going to the ER for echo time.
Okay.
And walking around with an ultrasound attending trained physician in an ER and doing echoes and getting interpreted images. That's something I'd like to see become the standard of care. We're definitely not there yet, but I think that could be what it is. But as for what's out there now, there are cases of 4-hour training, 6-hour trainings, 8-hour trainings. And the one that I presented on this morning, they did a 4-hour training that had really great outcome actually with their images they obtained.
So we have the ability to actually educate our staff on how to use ultrasound properly and where to use it. Give me the top 3 settings you think that ultrasound has use in EMS?
Yeah, I mean, the number one is going to be definitely undifferentiated shortness of breath, in my opinion.
Okay.
I think that being able to differentiate between CHF, COPD, pneumothorax, even pneumonia, once you're an advanced user of ultrasound, you can detect at least a large pneumonia for sure. I think that the next one is going to be in trauma, without a doubt. Especially like where I grew up working in EMS and where my area I still work now in the ER in, our providers are really tasked with determining, are we making a 45-minute ride to a trauma center calling a helicopter, or are we going to the local community hospital?
Right.
And I think that in situations like that, that can really help play into your decision-making and your patient care. And the last one I think would be undifferentiated chest pain.
Okay.
Ultimately, I've had patients with undifferentiated chest pain that I found cardiac tamponades on I wasn't expecting, people in acute decompensated heart failure that I was not expecting. So I think that is probably the next use. And if I had to give a honorable mention, I think vascular access would be definitely the number 4.
So that's something we do in the field a lot. How would the ultrasound work for vascular access?
Yeah, so I'm not here to preach that someone who is clinically unstable, your unresponsive patient with hypotension, 60s over 40s, I still think that IO or an EJ, if you're having difficult time getting normal peripheral vascular access, is the way to go.
Right.
But we have that subset of patients, a pretty large subset, that are mentating well, they're alert, maybe they're a chronic vasculopath, and you're having difficulty getting access on them. Pressure is 98 over 74, and they're otherwise stable. I think that actually using that to find a vein, put an IV in, and start the appropriate treatment pre-hospitally is much better than what we do now, which is a lot of times 3 strikes and you're out.
Yeah.
And we either drill you or we just do nothing and babysit you all the way to the hospital.
It's kind of like that middle ground where you have, if someone is not particularly sick, you can take the time to find an IV. If they're very sick, you give them an IO.
Yeah.
And sort of that middle ground where, they're not quite IO sick, but we have a little bit of time where we can work with them. And then with ultrasound too, if someone is a traumatic injury, we can also check, their actual preload, see how their left ventricle is working. So it seems like one of those tools that it's not just a single use thing. The cardiac monitor is also not just single use. So you can see AFib, various illnesses. It seems like one of these tools that we're going to get into our toolbox that will almost have us better diagnose and better treat patients, where we're recognizing illnesses and syndromes pre-hospitally and then bringing them to you to be able to give a different type of support.
Yeah.
So before we get out of here, one last thing, what message do you have for people who might be a little bit resistant to the kind of change that ultrasound brings?
I mean, it's like the Overrun logo, do better, right? I mean, I say it like half joking, but I mean, truly, that is what we're trying to do. We're trying to advance things. You see advances with whole blood. You have advances with the BLS scope of practice, at least here in New Jersey, where this conference is. I don't think we should stop now. It was really exciting, this conference, and looking at the changes that come to the scope of practice at the BLS and ALS level, that we finally feel like we have some good news, right? Some things are starting to move in the right direction, and I don't think we should stop. And I think ultrasound might be the next big game changer for EMS.
Beautiful. Dr. Devin Dromgoole from Robert Wood Johnson here at the New Jersey Conference. We'll be right back.
This episode of the Overrun podcast is brought to you by Team Life. Your hands can save a life. Learning how to perform high-quality CPR can be the difference for someone experiencing cardiac arrest. Team Life offers CPR certification classes throughout New Jersey taught by trained professionals. Sign up today for CPR certification classes at teamlife.com and learn the skills necessary to save a life. Anyone can be a hero. Now back to the show.
All right, welcome back to the show, guys. We're still down here at the New Jersey Conference, and I have our friend Dr. Garrett Cavalieri here to talk to us about some of the presentations he gave. Garrett, tell the people who you are, give them some of your background, and we'll get into your talks.
Sure. So I'm Garrett Cavalier. I'm the medical director for Lifeline Critical Care Transport. We are the critical care transport division within Penn State Health. So I'm the medical director of 4 helicopters, 3 bases, 2 ground critical care units, and then 2 physician response vehicles. We also have our EMS fellowship program and operational EMS physician program, and all things academic emergency medicine. Ed, thanks for having me.
That we are.
Oh my God, yes. And coming as a Maryland grad, coming over to Penn State, and I get all these weird looks when I have my Maryland Terrapin mug, and they just kind of look at me. I'm like, look, at least it's not Ohio State.
I mean, it's fair. That's fair. As long as you're wearing Eagles garb out there, you're fine. You're good to go. So you gave a couple talks at this conference, and I thought they were really important and interesting. You talked about aortic dissections, and you talked about traumatic cardiac arrest. So give us just kind of a 10,000-foot view. Talk about aortic dissections, because I think it's something that we are aware of in the field, but we probably miss it more than we should.
Sure. So the big thing with aortic dissections, we suck at diagnosing them. And that's one of the biggest takeaways from this talk. We can't diagnose aortic dissections for anything. Yeah, AAAs, everyone was like, okay, yeah, abdominal, 65-year-old with some pain, they smoke, we're gonna get it. But aortic dissections, we miss. Now, do we miss it the first time? Yeah. Do we miss it the second time? Yeah. Do we miss it the third time? Sometimes, but they're usually pretty close to dead, so we'll catch it on the third time.
Well,
So
hey, at
you're
least
missing.
we're very consistent.
Exactly. And now, the funny part is when you're looking at this literature, we're not just talking about in the emergency room. we're talking about all comers. So we're talking about pre-hospital providers, we're talking emergency departments, we're talking about urgent cares, we're talking about doctors' offices. Everyone misses dissections. And the reason is no one really knows how they present. You've got your classic triad of that burning, ripping chest pain, hypertension, cool, pale, diaphoretic. Okay, great. That's less than 15% of patients. What about everyone else? Oh, chest pain and, which is really the next big takeaway from this talk is when do I think of aortic dissections? Chest pain and leg pain, chest pain and stroke-like symptom, chest pain and lower back pain. Because you should have something. You should have something that shows both sides of the diaphragm. Because usually when we're talking about these really clinically significant aortic dissections, we're talking about these Stanford type A dissections. We're going up, we're taking out that aortic root, we're going down into the descending aorta, and then we're going to have all the complications from that. Keep in mind, it goes up into your coronary arteries, we're going to have stroke-like symptoms. It goes back to your coronary arteries, you're going to present like a STEMI, right? You've got your two coronary ozes, you've got your right and your left. You could present like an anterior STEMI, you could present like a inferior wall STEMI, depending upon where it goes. If it ruptures, you're going to have aortic insufficiency, so you're going to present more like heart failure. Or if it goes back around the heart, you're going to create a tamponade and you're going to have an obstructive physiology. Keeps on going down, it dissects and gets that ligament and artery of arch, AUTZ, which is in charge of your spinal column. It supplies your spinal column. You'll present with quadriplegia. It goes down into either one of your legs. You'll have an ischemic leg. So basically, any way it can present, it will. But think of chest pain and.
So
that's
it's funny listening to the descriptions because it gives me flashbacks to med school where like, oh, remember the ligament of Treitz just kind of sits back there, and it sounds like it's hard to listen to because it sounds kind of buzzwordy, right? Like you have all these anatomical definitions, but it sounds like what it comes down to is we're taught to look for pulsatile masses, and if there's no pulsatile mass, then there's probably not an aneurysm, right? And given that, I worry that we focus more on the patient who's about to dissect, right? Like they've got that pulsatile mass, they've got unequal blood pressures and all of that, but I feel like most of the clinical picture is kind of missed. So go into some of the risks of treating these patients, right? So if we see chest pain and chest pain and stroke-like symptoms, we might just think that it's an MI with altered mental status. So how do we go through, I guess, that clinical care while keeping a high index of suspicion for an actual aortic aneurysm?
So there's actually no risk of treating these patients because the first thing you ever want to do for these patients is sympatholysis. So you're going to treat them very aggressively with pain management. This is not the patient you're giving a gram of Tylenol and 15 of Toradol. One, you shouldn't really be giving them Toradol anyway because of that whole bleeding risk. But when you're treating them aggressively, especially with fentanyl, and this is where I definitely prefer fentanyl over our other opiate medications. So our hydromorphones, our carfentanyls, if you're in more of the anesthesia side or the anesthesia critical care side, or your morphines. Fentanyl is really, really good at sympatholysis. So it's going to take that patient, and they're dying, right? They are literally dying in front of you. So of course they're anxious. But what happens when they're anxious? They're going to increase that blood pressure. They're going to increase that heart rate. So what is that going to do on that wall tension? So you've got this aortic dissection. It's actively ripping down. With each pulsatility of your heart, you're getting that pressure, 250 systolic, banging that wall. Why? Because your body wants to live. Right. So what do I want to do? I want to decrease that blood pressure. I want to decrease that heart rate. I want to decrease that anxiety. How do I do that? I give them a big slug of fentanyl. This is not where I'm giving them 25 mics of fentanyl. I'm hitting a good 1 mic per kilo up front and repeating that every 5 to 10 minutes until I get the effects I'm looking for. Now, once I have great pain control, then we can do the other things.
And if we have a patient with chest pain that's presenting as a STEMI, can you walk me, what are some, I guess, hurdles for differentials, right? Because that's not someone that I want to give nitrates and blood thinners to. If they're having a dissection and not an MI, how do you, I guess, kind of juggle that treatment in the field?
So that goes back to the chest pain and. So they come in, they stereotypical chest pain, right? I've got chest pain, I'm short of breath, I've got diaphoresis, looks like a duck, quacks like a duck, is probably a duck. Now, what about when they say, but I'm also having like lower back pain and my right leg feels weird. And then you look at the leg and you're saying, hey, how come this leg is pale? How come you've got this weird lower belly pain that I wouldn't really expect? How come you're also having stroke-like symptoms? You're having that chest pain and it's really that and is that key part of the diagnostics, especially when you're getting history. that you really need to consider.
That's fair. And so the other talk you gave was on traumatic arrest, and it feels like these topics kind of tie together, right? Where if you can have someone who has a medical aneurysm and then maybe it ruptures in a traumatic accident type of situation. But go talk to us a little bit about the traumatic arrests and what you talked about this year.
So traumatic arrest. So this big talk, it's actually a really fun discussion. And basically it's how we're treating most of these patients wrong. If you're doing ACLS, you're doing it wrong. If you're doing standard therapies, you're doing it wrong. And then we focused around the main interventions that actually save lives in these circumstances. So we talked about some dogma, which is chest compression. Ed, how many times have you gotten on scene of the really, really bad car accident or shooting, a stabbing, and every time they do a compression, blood is spurting out some hole?
Right. The thing that we're going to replace is what we're losing.
Exactly. So chest compressions kill patients. We went through the actual history behind it. So we went through one of the studies, the original study looking at this, which was a baboon-based model. Then we went through a more recent study in 2019 that looked at whole blood plus chest compression, saline plus compressions, or just saline or just blood administration, which showed that you have better ROS rates with just giving blood than anything else. And then I didn't even talk about it because it just got published a couple of days ago, but in the Journal of Trauma, they had a chest compression study where they found that there was a 100% mortality rate in traumatic cardiac arrest with closed chest compression for age greater than 70, and like a 98% mortality rate in ages less than 7.
Right.
So that study just came out too.
So bad.
So we're killing people. We are
Right.
literally killing people by doing chest compressions. We're also delaying time to critical interventions. So what are critical interventions? I need to decompress their chest. Looking at the military literature, why these patients die? They have tension pneumothoraces or they've got cardiac tamponades. Now in the pre-hospital environment, unless you're in a very high level flight program and you're doing blind pericardial centesis or you're on a physician level unit, you're flying fast, you're driving fast for those patients. But for everyone else, bilateral needle decompressions, they don't work. Look at the Ken Gianabba literature, look at the military literature, you're not penetrating the chest. What works 100% of the time? Finger thoracostomy. Put a finger in their chest, we decompress their chest. Why else do these patients die? Failure to establish a definitive airway. I don't know why we're still having this problem in 2024. We know what this says. Can't intubate, can't ventilate, you're cutting the neck. Very fluid. But we're still seeing people are afraid to make the decision. Next thing, pelvic binders is another big one where it's people just forget to put them on. Most of the time, pelvic bleeds or venous bleeding, which is very amenable to external compression. Very rarely are you getting a superior shear. Anytime you've got your lateral shears and your open books, if you put a binder up, you keep everything in position like this, you're going to do just. Now, I agree. If they fell on their feet off a building, we wouldn't want to put a pelvic binder on that patient because you get this vertical shear and then you put a binder on it. All it's going to do is rip everything and as it goes like this.
Yeah, just make it worse, right?
But most like motorcycle accidents, motor vehicle collisions where your pelvis is literally shearing like this, put a binder on. You'll be fine. And then we talked a lot about very early and aggressive blood administration, not giving crystalloids.
And I think all of that tracks and makes sense. And I share your frustration, because you and I have been having this conversation off air for at least 5 years now. And so I guess one of the questions that I always have is there seems to be institutional resistance to getting whole blood products put onto vehicles. And I wonder how much of it is, financial or operational, but I think a lot of it too is just resistance to change. So when having these conversations, and now you're in a position where you're directing a whole trauma program, like these are decisions that you get to make. We've heard and we've talked about, finding a champion, finding someone to kind of spearhead the project. What's your answer? How do you respond to people who want whole blood out on the trucks and, to get them out to the populations, but they're meeting, sort of managerial supervisor type of resistance?
So the best way, and we just switched over from PRBCs to whole blood a couple months ago. So the biggest challenge, depending upon where you are, is supply. So a lot of times, and you need to look through your supervisors, your leadership's lens when they're saying no. And I doubt they're saying no because, we don't want whole blood. No, everyone wants whole blood. The literature is very clear on this. Pre-hospital whole blood given as close to the point and time of injury saves lives. It decreases your MTP rates, it decreases total product administration, it decreases mortality, it decreases morbidity. We know this. There's been literature dating back to World War II where that showed whole blood at the point of injury saves lives. Component was a lot easier because it has longer shelf life. Keep in mind, whole blood has a shelf life of 3 weeks, which realistically turns into an operational period between 10 to 14 days.
Yeah.
So if you're not frequently using blood, this can be a very expensive venture. Keep in mind, 1 unit of whole blood, depending upon where you get it from, between $700 and $1,100. PRBCs are anywhere between $250 to $350. So we're looking at more than twice the cost. And if you're not using it, you need to make sure you have a blood bank where you can cycle. So the first question you have to ask, are you saying no because of the logistical challenges with getting whole blood, or is this a blood problem in and of itself? We had blood. I have the luxury of being attached to a hospital-based system where I've got a blood bank that's across the parking lot, where I just send our landline, which is our pickup truck that we pick up the crew, go get more blood. The other helicopter comes in, perfect, go swap out your blood. So I'm easy in that circumstance. Other county-based systems who've switched over to whole blood were having some real challenges. Local blood banks couldn't support it. They actually had to go out of state to get blood. They had to contract with a courier service. So every 10 to 14 days, they're having a courier bring new blood up and they're bringing old blood down. The next concern is, okay, great. Now I used blood. How am I going to replace that in real time so I'm ready for that next job, ready for that next patient? So having a backup supply as well. So going through the logistics of having a supported blood bank and knowing what you're going to do, you need to have all of these ducks in a row before you can have an operational program. The next big things are once you say, they say, yes, so like, we want blood. How do we do it?
And I think once you get all of that, then you can develop a program to get blood out onto the truck. But I think that was really the biggest concern, right? Is how do we figure out operationally that this is an effective tool? Like clinically, we've already figured it out, right? We know that the data is extant. We know that whole blood is the solution. So that's not really the argument anymore. It's just, how do we get it on the truck? So if I'm at a project that through, cost or availability or concern, we don't have whole blood, and we don't have, we don't have component parts. We just have, your standard EMS stuff. What can I change in my resuscitation strategy to try and improve the outcomes of these patients?
So to answer that question, first you have to look, is this a BLS level or an ALS level? And hopefully if we're talking about at the critical care and the flight level, you have blood problems. So at the BLS level, what can you do to change outcome on these patients? Don't do closed chest compressions because you don't want to just squirt blood everywhere. Good BLS airway skills. Please don't put a nasopharyngeal airway in them. If you really want to Google some pictures, you can, where you can see nasopharyngeal airways going directly into the brain parenchyma. So please don't do that, but open up the airway, get a good jaw thrust going, two-handed bag technique, ventilate this patient, prevent hypoxemia, prevent hypotension as best you can, stop any visible bleeding, so go through your cab mnemonic, and then as best you can, rendezvous with an advanced provider. Don't delay transport, don't wait on scene for 15, 20 minutes for ALS. Start moving towards your closest quaternary care or advanced trauma center so that you can get care going. If not, activate flight, get your flight providers on scene, let them start treating the patient. At the ALS level, it's always move towards your mission, go towards your destination, and make sure you're doing your basics first and then taking that chest. Do not delay taking the chest. This is not the time where you're like, I'm not sure, I don't know. You're peri-arrest blunt trauma patient, you're taking that chest, that's a reversible cause, do it early. And then really, I caution on how I want to word this, but be very leery on just giving all of the normozoline. And by normozoline, you mean, I'm talking about normal saline.
Yeah.
Frequently, you'll see them just put up a liter of normal saline and just run it in. All we're doing with that is we're cooling down the patient, so we're creating hypothermia. Remember, normal saline, it has a higher level of chloride ions, higher level of sodium ions than your than your normal blood. So it's actually acidic. So you're going to create an acidemia, a non-anion gap, hyperchloremic metabolic acidemia. So now they're cold, they're acidotic, and now all my regular clotting factors have now just been diluted. So now I just created a coagulopathy.
Everything that we're doing that we're supposed to do is actually making traumatic patients worse.
So I literally just gave you the deadly triad of trauma that you just did by trying to resuscitate this patient with normal saline.
That's what we're doing by trying to help, is we're facilitating the problem.
I mean, that's almost as close to a clean kill as possible.
Right. Yeah, it's a lot. But Garrett, we're going to have you on the show later next year and try and go over a bunch of this stuff in a lot more detail. But thank you for your time. Really exciting talks. Garrett Cavalier from Lifeline out there at Penn State. Thank you for your time, guys. We'll be right back.
It's always a pleasure.
Hey everybody, it's Ed, and I want to tell you about the Monday Afternoon Journal Club. It's a new thing we've been doing on the Overrun here on YouTube, and we're really excited about it. We've gotten a lot of really good feedback for it. What we're doing is we're taking new journal articles that have been published within the past year, 6 months, 3 months, and sometimes even the past couple weeks, and updating you about new EMS information, whether it's clinical care, response times, operations, all of those things. We're bringing you the newest EMS data. So subscribe to the Overrun on YouTube and check out the Monday Afternoon Journal Club most Monday afternoons. Now back to the show.
All right, and welcome back to the Overrun podcast. Ed Bowder and Dan Schwester here. Danny, we had a great time at this conference in Atlantic City last weekend.
Yeah, it was an excellent time. A lot of strong educational presentations, an inspiring talk from Chief John Moon, who we've had on the podcast, so we'll link to the episode, about perseverance and just the grace and the dignity of fighting the good fight. This guy has been through so much and became a leader. And no offense, everybody, if you don't get out to see this guy, you're gonna regret it. If you don't read American Sirens, you're gonna regret it. Go back to the episodes. We've been lucky enough that Emmett as the author of the American Sirens, and we got to speak to Chief John Moon, arguably probably the first paramedic in the United States to perform endotracheal intubation. If he blew it that day, gang, maybe not us. Maybe it doesn't happen. But he didn't. He got a first pass success in the operating room with none other than the father of resuscitation in the United States, Dr. Peter Saffer, looking over his shoulder. Big stuff, amazing stuff from the conference, which is the New Jersey conference. It's called the National Conference on EMS. We can talk about that, but
yeah.
Overall, I would give it a solid B+. Great learning opportunities, and yeah, let's get into that because I want to see what did you like, because I want to get to what I like, and then we can talk about what we didn't. So what did you think about?
What I really liked, and I agree with you, John Moon is, if nothing else, he's just a really cool guy, right? Like we had a chance to sit and talk with him for a bit. We did have him on the show last year, which was really great, but actually getting a chance to sit and meet with him and talk to him for a couple minutes. Just one of those people that like you like to meet, you like to sit and talk to. We tend to oppose talking about war stories, but I mean, just listening to Chief Moon was really inspiring, and being able to have that conversation with him. One of the things that I always like about conferences is that there's a lot of different opinions you can get. There's a lot of different providers that you can meet. We talked previously in this episode with Dr. Dromgoole and Dr. Cavalier talking about ultrasound and whole blood being put out into the field. And, I wanted to have those guys on the show, aside from that they've been friends of ours and friends of the show for a while. What they talk about is stuff that's extant in the data, right? Yeah. And that's what's always interesting at conferences to me is that it's so easy, I guess, to access data right now, whether it's Google Scholar, PubMed, you can search all the NIH stuff online for free. There's a lot of people who don't have access to this information and this data, so they tend to get it at conferences. And the issue with that is that people don't go to conferences every year. You end up having to try and so in the state of New Jersey, I will say there's about 25,000 providers, and there was only about 1,000 people that attended this conference. Now, 1,000 people at a conference is a great number, but you have to do it 25 times to get all that information out to people. And that's why we always run into similar topics over and over and over again every year. So it's this kind of self-consuming cycle that we run into where we know that whole blood in trauma works. And it makes sense because if you're losing blood, the thing that you should be, given is blood. If you lose blood, giving saline doesn't carry oxygen, it doesn't do anything. So year after year after year, we have to have these conversations. Dr. Cavalier gave a great talk where he was talking about in traumatic arrest, we probably shouldn't be doing CPR, which is something that has been discussed academically for 4 or 5 years now. But I think coming in with the approach of like, listen, instead of doing CPR for traumatic arrest, we have to do finger thoracostomy and we have to get to the hospital, just decompress their chest cavity, make sure there's enough space for the heart to beat. So I think all those talks are important. My hesitation in conferences is that taking that one class, I'm not convinced gives you all the tools you need to succeed going out into the field afterward. But that's really more of a format change. And I also don't have an answer to it. right? Like, I don't know how you can do an in-person conference with 1,000 people and then still try and get all the information out without making it like a mandatory annual thing. So what I do think is important, though, is I think there's a lot of different topics. There's a lot of different people that are talking, so you get a lot of different points of view. I think that the networking aspect of conferences is largely overlooked. You and I had a series of great conversations with a lot of really good thought leaders. I think a lot of people are kind of intimidated to talk to some of the thought leaders out there for whatever reason may be out there.
But that's what they're there for.
Right.
They didn't come to not talk to people.
Right. No, exactly. And so, the people that we see out there, we talk to, I mean, I feel like I'm name dropping here, but, we talked to a bunch of people that were out there. We had Amy Eisenhower, Tracy Loscar were out there. So having the opportunity to have these deep conversations with, all right, I appreciate what you're doing in your system. I don't know how applicable they are to my system. What ideas do you have? And you can have those informal conversations while also listening to their big presentations and seeing the new data that they put out. So I gave a pretty long talk. My talk was called, We Need to Talk About Carl. What I did was I invented a patient that was born in 1950, and I essentially took him through his pathology throughout his whole life. So, now he's 74, he's got COPD, CHF, history of MI, history of, diabetes, stroke, whatever. And I went through physiologically how those things happen to him over time. Anna and Caroline gave a really great talk on how to engage your students, which I thought was very, very important because we're not doing it enough, right? If you have a classroom setting and your students just aren't really getting what's being taught, the onus then is on the instructor to figure out better ways to teach, right? I think that they made a really good point it's when you're in an educational program, it is the educational program's responsibility to impart that information onto the students. It is the student's responsibility to learn, but we have to give them an environment in which they can learn. Now, that might involve growing pains, that might involve, challenges to your particular dogma, but it is very important to get it out. So, net positive, I agree with B+. There's always advancements that you can make. I'm not sure that A+ is actually possible at any conference, so it's also a weird sliding scale. But those are my takeaways. I like seeing the people, I like the talks, I like the information, and I like the networking availability that you have.
Yeah, I think you hit a lot of the same notes that I'm going to talk about. First off, I want to say that I had no idea what you were doing with Carl, and because you were not telling anyone, and it turned out to be a very thought-provoking discussion about, we tend to discount or we tend to look down on patients for the diseases that they've acquired over a lifetime. Right. And, I thought that you kind of really hit on the ethical aspect of, hey, you know what? Like, when he was a kid, everybody smoked because the doctor said it was healthy. And you back that up with the ads that were literally in the magazines all over the country. That some of this stuff is not necessarily as much their fault as you might think it is.
Yeah.
It was very well received. I took it cold. You never even showed me the slide deck, and I just walked in. I was like, "Oh, we're almost done with this. This is great. This has been a fun ride. I enjoyed it. I looked around the room. Tons of people were enjoying it. Anna did some really amazing work about about resuscitating your stagnant programs.
Yeah.
Talking about mental asystole.
I'm gonna paraphrasing her title. It was Recovering Your Program from Asystole, which is it's a great title, talk title. Yeah. Like the content notwithstanding, that's a good way to get someone into the talk.
Yeah. And she did a fantastic job with that. I thought I did not get to see Caroline and Anna's talk on Tales from Rookie World. Although, if you've been following us, you know the Rookie World blog. You know that Caroline was a brand new EMT. Her first two patients died right in front of her. And, going through EMT school as a legacy, as someone whose father's done it, and, now she's doing it, now her brother's doing it. If you get a chance, we'll link to it in the show notes. I think the Rookie World blog is something for everybody to look at, whether you're a new EMT and you're like, God, I'm so lost. I don't know what the hell happened. Yeah. Or you're an experienced instructor or preceptor and you're like, what's going on with these kids? this is somebody who's going to give you a perspective on it. I thought that was good. Um, the other thing about that I took from the conference was ultrasound and whole blood. Those were the big ALS things. I was lucky enough to go to the pre-conference seminar by another friend of the show, Jocelyn Dr. Joseph, and Dr. Dromgoole. It was a 4-hour talk. It was a 4-hour presentation and interactive lab on using ultrasound in the field for cardiac standstill, for lung sounds, for ultrasound guided IVs. A little bit of fast scan, but not much. The thing that I took away from that was this is absolutely something we should be thinking about in EMS. ALS clinicians can do this pretty effectively. They backed it up with the data that showed that we can do it and interpret it, and we can get the same results that physicians get in the hospital. And again, nothing ventured, nothing gained. I was a little, I'll get into my disappointments after this, but I really want to hear what you had that you kind of thought where they fell a little short, where they need to step up. But I don't think they lost on the educational programs this year.
No, not at all. I think what they taught was very good. I think the challenges that any conference faces is you have to try and get information that will attract the biggest audience, the most amount of people, while having, the least amount of kind of nuance, right? I think it's very difficult to put together a conference where each block, so the way this is laid out is each block is about an hour and 15 minutes, an hour and a half. And given that there's 4 or 5 talks that occur within that hour and a half. And one of the problems that you hear every year is that I would have liked to have gone to 2 of those talks that happened at the same time. So one of the best things that I encountered at a conference is I went to a conference in, 2011, 2012. And what they had done was they recorded all of the talks. And so you had the luxury of going to a talk, and then on the back end, when the conference was over, all the talks were sent to you.
Yeah.
So you still got your CME, but if if I wanted to go to a talk about whole blood, if there was a talk at the same time as ultrasound, I would have to choose one. But this conference sent out the actual MP4 files of all the talks. So you're able to get them in aggregate. So you got, all of your CEUs from being at the conference, but you also had all the talks. The rub with that is that you don't get the CEUs from the other talks, but one way or the other, you're at least able to get the information from it. So that's usually my biggest thing, is that it feels like there's always a lot of information that's out there that people are trying to get. And then what ends up happening is you invariably miss 1 or 2 talks because there's just too many. So, and that's more of a critique. I don't know about a criticism. In any conference, you're always worried about, the acumen of the speakers and the expertise of the speakers. I didn't see a big problem with that this year. I think everyone that was talking had, was eligible, I would say, to speak about what they were speaking about. But pretty much my critiques of any conference will always come down to scheduling.
Yeah, I agree. I got to admit, I had a couple FOMO moments during the week of where, God, I really want to go to this, but I really have to go to this. And it's a lot of educational triage as you're like, what's going to benefit my practice? What are the things that I can bring back to my clinical staff and say, hey, we should be thinking about this. We should be discussing this. But yeah, I missed out on a couple programs. I think having it recorded for later review just for the educational benefit without CME would be a great idea. Big one.
Right. And something that I noticed at this particular conference, and again, this is anecdote, this isn't data. I did notice there were a bunch of organizations that had 1 or 2 people that came down. How that happened, whatever, I don't really care. But I do think that if you have a large organization and you're trying to progress as an organization, one of the best things you can do is send a bunch of representatives from that organization down to these conferences. Specifically, because to make a good showing, if nothing else, right? You can show out, be like, hey, ABC Town EMS rolls out in force to this conference. But more importantly than that, if you spread out the amount of people that are going to the talks, you get more information back. When we're at these conferences, Danny, you and I never go to the same talk.
No,
right? We pretty much split off because we want to.
Right. We meet and share notes and compare. And
And so we always come back to it. And again, this is, trying not to throw out the good in pursuit of the perfect, where, if you have 5 people that go down and there's 4 talks every hour, you can rotate so that everyone sees some of the information so you can get it back to your organization. I think that organizational logistics are kind of difficult in conferences because everyone kind of wants to do their own thing. frankly, down here, it is a weekend in Atlantic City, so there's variables that you can't control for down there. So it's a net positive. Again, it's always good. There's probably some improvements that we can be made, but generally speaking, I thought it was a really good experience. But we want to know what you guys think. Let us know about the first two talks in this episode. The segments with Dr. Dromgoole and Dr. Cavalier, they're two physicians that we've worked with for years. They're very, very good at what they do. They're very, very knowledgeable. We are excited to hear your input and your thoughts. Check us out on Spotify, YouTube, Apple Podcasts, and everywhere that you get all of your information for the Overrun. I'm Ed Bowder.
I'm Dan Schwester.
And we will talk to you all next time.
Take care, everybody.